Good morning and afternoon. My name is Tracy Cook and I'm with Saks Healthcare Communications. Before I introduce our moderator today, Angela Craig, and our speakers, Lisa Owen and Tamara Stern, I would like to show our audience how to send in questions and comments. You can type your questions into the questions pane. You may send your questions at any time during the presentation. We will collect these and address as many as possible during the end of today's presentation. You can also download the handout from the handout section of the GoToWebinar control panel. Our moderator for today is Angela Craig. Angela is the clinical nurse specialist for the ICU and the sepsis lead for Cookeville Regional Medical Center in Cookeville, Tennessee. She has lectured both locally and nationally on topics of sepsis and hemodynamics. She has published on the topic of sepsis and has co-authored on the topic of heart failure. The last 2 years, she has worked extensively with the many COVID-19 patients in our ICU and worked with staff on ways to better care and treat this population. She also sits on the Physician COVID-19 Task Force at her hospital and has helped update the COVID-19 guidelines for their hospital. Angela, welcome.
Thank you, Tracy. Good morning, good afternoon, depending on what time zone you're in. Thank you for that kind introduction. And the title of today's webinar is What We Learned Implementing a Mechanical CPR Device During the COVID Pandemic. Speaking on this timely topic is Lisa Owens and Tamara Stern. Lisa is the clinical nurse specialist and the acute shock program coordinator at URMC in Rochester, New York. She has over 12 years in cardiovascular intensive care nursing experience, and she is the manager and educator for both the ECMO specialist team and the adult critical care transport team. In addition to her clinical experience, Lisa has presented numerous lectures at her facility and at national medical conferences on topics related to critical care transport, ECMO, and resuscitation. Tamara is currently the clinical nurse specialist at URMC in Rochester, New York. She has nearly 20 years of clinical nursing experience, primarily in cardiovascular intensive care. She has recently created a code committee to implement a new standard of care in cardiac surgery resuscitation. She is a dedicated educator and mentor. Our disclosures today are for Lisa Owen, is a consultant for Stryker International, and Tamara Stern, a consultant as well for Stryker International. Continuing education for nurses and respiratory therapists will be approved for 1.0 contact hour of continuing education. And at the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. The accreditation statements are listed below, and support for this educational activity has been provided by Stryker. And now I would like to turn over this awesome topic to Lisa Owen and Tamara Stern.
Hello, everyone, and welcome. Thank you so much for joining us today. I'm Lisa Owen, and I'm here with my CNS colleague, Tammy Stern. We're going to talk about what we learned implementing a mechanical CPR device during the COVID-19 pandemic. COVID had a huge impact on the way that we care for our patients. We're going to share with you our experience in making a system change and developing new initiatives that involve this new device. Just for some clarification purposes, I want to bring up a couple terms that you're going to hear frequently in our presentation. The first one is MCPR, which is simply mechanical CPR. It refers to the device that we use. Secondly, you're going to hear us use the term ECMO, which is ECMO corporeal membrane oxygenation, which is a form of advanced life support therapy that is used to support the heart and lungs for patients that are suffering from cardiac and pulmonary failure. Lastly, you're going to hear the term ECPR, which is extracorporeal resuscitation, and that is used when we put someone on ECMO during cardiac arrest. So with that being said, let's go ahead and get started with our presentation.
Hi everyone, like Lisa said, my name is Tammy. And I'm just going to go over a few of the things that we kind of want you to learn today while we're going through our experience. Number one is discuss the importance of high quality uninterrupted CPR. And from the AHA, this tells us that anytime we get interruptions during CPR, it actually decreases the patient's chance of achieving ROSC. And we also want you to kind of understand where can you utilize mechanical CPR in your own protocols, in your own hospital, where we utilize it in the ED here, we utilize it in the Cath Lab, we utilize it on our own unit, we utilize it during our eCPR resuscitation. And then kind of like how two CNSs kind of navigated through a resistance of change in traditional practice, and like how did we do that in this large facility and kind of get all the people we needed on board.
So I'm just going to tell you a little bit about our program here in Rochester called UR Medicine Cardiac Care. So our team provides state-of-the-art heart care to all of upstate New York and the North Country. We serve as a regional hub for cardiogenic shock, and we receive referrals from 31 outside hospitals. That process is supported by our own nurse-led critical care transport team that specializes in the transfer of patients on mechanical circulatory support, balloon pumps, impellas, and ECMO. We are the region's only experienced advanced heart failure program. We have a large LVAD implant program. We've done close to 900 LVADs here. We're the only program that does heart transplants in this region. We've done 300 heart transplants, and we are a very large ECMO center. Our program first started in 2004, and since that time, we have implanted over 1,000 ECMOs. When the pandemic came, we thought that maybe our program would be slowing down, but with our hospital becoming a designated COVID facility, we learned that putting patients on VV ECMO, when we adjusted our protocols, we were actually able to save lives doing that. So that helped increase the number of ECMOs that we were doing as well. So just a little bit about what we do here.
So as everybody is aware, January 2020 brought kind of unprecedented times around the United States and internationally. Our first case of COVID came, and the frontline healthcare workers were suddenly faced with these unprecedented risks to exposures. We really had no idea how is this disease spread? You know, how lethal is this disease? You know, our traditional practices that we were doing weren't going to work during this time. And what are the new protocols? What are the new, you know, ways of doing things? So I feel a lot of hospitals and our hospital created these COVID task force. And I don't know if everybody's aware, but these COVID task force were Zooming with other hospitals nationally. They were Zooming with international hospitals, really trying to figure out what's the best practice here? What is the best protocol for PPE? What's the best treatment for these patients? You know, everything was so kind of up in the air and what was going to work best, you know? So just getting together with, you know, other hospitals and kind of, you know, going through and saying, okay, well, this is best practice. Why don't we try this out, you know? And then how did this affect all of our implementation of our resuscitation protocols that we already had in place? You know, now we're going to be changing some of the practices and changing some of the roles. So how, you know, what do we do? How are we going to do this? And kind of like, what type of challenges were we going to see during this unprecedented time?
You're trying to steal my line. So let's talk about the challenges that we faced during that initial surge of the COVID pandemic. So the nature of the global pandemic had placed huge logistical stress on many aspects of the healthcare system. We were suddenly having shortages of IV poles, power cords, testing supplies, materials to clean. And on top of that, there was a shortage of PPE. You know, we were forced to be reusing masks, and it just really caused a lot of stress on the system. The high prevalence of the disease and associated mortality possessed a huge risk for our healthcare providers. We had up to 5 ICUs at one time that were full of COVID patients, and our staff were experiencing daily exposure. They were having to reuse PPE, and we just truly didn't know enough to be able to keep everyone safe. Large-scale exposures, again, that I just talked about, required quarantine for staff, for our patients, and it just really stressed our system. These COVID patients, they were a really sick population. They were patients that were suffering from respiratory failure secondary to ARDS. They had myocardial injury. They were having ventricular arrhythmias. they were exposed to shock, which predisposed them all to cardiac arrest. And we know that in resuscitation, it's very physically demanding. It's time sensitive. When someone arrests, we need to immediately get in that room. When we're in that room, we're performing high risk procedures such as intubation, bagging them, doing emergent procedures like getting arterial access and placing them on ECMO. And at this time, the risk of exposure and infection to the healthcare worker that was involved in that resuscitation process, we just didn't really understand the implications from COVID.
So talking about those challenges and that COVID task force, really the goal was to keep our healthcare workers safe and our patient outcomes still the same, you know, and ever better care. So what were some of the goals that our hospital came up with? You know, we really wanted to limit exposure to aerosol generating procedures. So limit the number of people that are in a room, limit the number of procedures. You know, is this procedure really kind of indicated in this, you know, in this situation, or is it not? You know, we needed to limit activities that might compromise PPE. So did 20 people really need to come in the room when there was a code resuscitation going on and get all that PPE on and kind of be wasteful? Did they or didn't they? So really kind of looking at that and what were the numbers? What did we need? What we need to do? And through all this, we really needed to still give our patients high quality resuscitation and high quality of care. Like we could not lax on that. Patients are the center of our care, especially, you know, surrounding what we do, our healthcare team. So Lisa's going to go over one of the solutions that we found for that.
Yeah, so one of the solutions actually came about in June of 2020. There was a consensus report that came out in the Circulation Journal, and it was called Interim Guidance for Basic and Advanced Life Support in Adults, Children, and Neonates with Suspected or Confirmed COVID-19. And this consensus report was put out from the Emergency Cardiovascular Care Committee and Get With the Guidelines, Resuscitation Adult and Pediatric Task Force. And what they did was they acknowledged that the American Heart Association CPR guidelines did not address any of the challenges that we faced with resuscitation during the COVID pandemic. 19% of COVID patients at that time required hospitalization, and up to 6% of those patients that were hospitalized were critically ill. They were at high risk for cardiac arrest, and what it led to was our healthcare workers were really forced to choose between the needs of the patient and protecting themselves from exposure. So the recommendation from this committee was to decrease provider exposure to COVID-19 by doing the following things. So the first thing was, during a cardiac arrest, to always don proper PPE during the event. So we had always told our staff, no matter what is happening, you've got to stop, properly put your PPE on, make sure that anybody that's entering that room with you has their PPE on properly as well, again, to decrease that risk of exposure. The next thing was to limit the number of personnel in the room. Designated roles during cardiac arrest. You don't need 30 people jammed into a room when there is a very high risk to exposure to COVID. And clearly communicating as new people entered the room during that resuscitation process. You know, if somebody came in without PPE on, acknowledging to them, this is a COVID positive patient. You've got to step out of the room and properly protect yourself. And then lastly, the most important thing that they addressed was in settings with protocols in place and expertise in their use, consider replacing manual chest compressions with mechanical CPR devices to reduce the number of rescuers required for adults and adolescents who meet the manufacturer's height and weight requirement for that device. So this was a way that we could protect ourselves.
So let's talk a little bit about mechanical CPR device and why it's so helpful in resuscitation events. So number one, we want to consistently give high quality chest compressions, and picking out this device kind of allows us to do that. So the AHA with their research lets us know that a compression rate of 100 to 120 is the recommended rate. If you go above or below that, you're really kind of reducing that patient's survival rate. So this mechanical device can deliver chest compressions at 100, 110, and 120 on a consistent basis. It also allows for a full chest recoil. So sometimes it's been found that people lean on the patient when they're doing manual chest compressions. This doesn't allow any leaning, so it allows that full chest recoil. And it provided like a hands-free CPR device during any procedures. When we do eCPR, we go on ECMO. We're utilizing the mechanical CPR device through the whole thing. It also limited the amount of team members needed in the resuscitation efforts. So the nurse at the bedside could do kind of multitasking. So if you were the defibrillator, you could also handle kind of monitoring the mechanical CPR device at the same time. And in the setting of COVID, it allowed us to safely distance ourselves from the patient and prevent direct contact with aerosol particles, which was very important in the beginning of COVID, and kind of keeping ourselves distanced and protecting ourselves so we can actually care for our patients. And it also allowed for effective chest compressions and continuous perfusion during, again, that extracorporeal cardiopulmonary resuscitation, the eCPR. And then kind of how did we put this out hospital-wide? So once we figured out the solution as the COVID task force was following the recommendations from that emergency cardiovascular care committee, how do we do this? So the hospital-wide initiative was, we had 3 devices in the hospital already. So we had it in the Cath Lab and we had 2 in the cardiac ICU. And how do we kind of utilize these devices and get them out? So we had to purchase 5 more devices for the hospital so that we could have 1 mechanical CPR device on every COVID floor. We also, the cardiac ICU gave up 1 of their devices, so that allowed for 6 to be out there in the hospital. And then not everybody knew how to put this device on. How do we kind of educate a mass amount of people during this time when you couldn't really have a lot of people together in one room? So we had to social distance at the same time. So we did have a lot of online resources. So we utilized something called Box, which is kind of like a overall, everybody can log into Box, and it's like folders and able to get in there and view videos, view PowerPoints, whatever you need. So we had that in a short term. We also did on-the-job training. So as nurses came in on their shifts, if they weren't trained in the mechanical CPR device, we had a mannequin there and we had the mechanical device there, and we were teaching them how to place it on and doing a skills sign off. And also there was always 1 person on shift that was an expert in this device. So utilizing them in code situations and having them be the one that went in and put the mechanical CPR device on. So during all this, Lisa and I, being CNSs in the cardiac ICU, saw all this evidence and best practice, and we said, how can we really utilize this in our actual protocols for the cardiac ICU? Can we implement it? Because we were going through this COVID pandemic. We were also launching a new program in our ICU, and it's a acute shock. We were doing an acute shock. So this was in June of 2020. And I'm going to have Lisa explain a little bit about our acute shock program.
Yeah, so what happened for us? So I talked a little bit about our ECMO program and how we started in early of 2000, I think it was 2004 was when we actually started. At that point, we were only doing 20 to 30 ECMOs at a time. So we had a perfusion-led program. We would have the perfusionists come up to the unit and sit at the bedside and care for the circuits. Then as time went on, we started to get better at this, and we started to get more referrals, and we started doing more VAD implants and more transplants. So our ECMO program increased, and now we were doing 50 and 60 ECMOs a year. Could not have our perfusionist constantly in the OR and constantly sitting on the unit. So we actually transitioned to an ECMO specialist program. And this was a group of nurses and respiratory therapists that worked a second assignment job as a specialist that would come sit on our unit and watch the circuit. This was working great for a really long time until 2015 came around, and we got a new chief of cardiac surgery, who we all love. He came here with the purpose of expanding our ECMO program And what he did was actually explode our program. So we shot up to 140 to 150 ECMOs a year at this time. And the current ECMO specialist model that we had was absolutely not sustainable. We had these staff members that were working continuous 5, 6, 12s a week trying to cover these circuits. We were running up to 10 ECMOs at a time. We had to do something different. And what we did is we took a look at what we had right in front of us, which was these amazing experienced bedside ICU nurses. So we took the ECMO coverage to those bedside nurses. We trained them. They now care for the patient and the circuit. We provided this acute shock nurse for them, as we call it, and we'll talk about that role in a little bit, to support them in that process. And in June of 2020, during the heart of this pandemic, we rolled out this new program, and it has been absolutely phenomenal for us. So that's just kind of a little bit about what that shock program is. So this little diagram is just a basic overview of the 4 components of creating organizational change. And I always use these 4 steps whenever I am developing a new program or creating new initiatives. I usually do it on an Excel spreadsheet, but for today we thought we'd cuten it up a little bit and make a nice little chart for you. So the first process in this is to identify opportunities in the process workflow. So for us, in the setting of COVID-19, this was the opportunity to reduce staff exposure during resuscitation. Second in this is to plan. How can the current process be improved? So we looked at that consensus report. We took that information from there. We looked at evidence, we created work groups, we involved key stakeholders, we got feedback from everyone, and we put together this new program. We had this vision, and we put it to paper. The third step of this is to execute. How can you implement this change? So Tammy and I did this huge educational program. We rolled out the new education plan. We started doing continuous simulation. We were doing mock codes with our staff. We developed these protocols. We created all these guidelines and what's called policy stat here, where people can go and see what our policies are. And we just did a ton of training with our staff in the sim lab, at the bedside with them. And then the last piece to this is the review. How were these changes that we made working for our staff? What were our patient outcomes? And we're going to talk about these 4 items in detail over the next couple of slides.
So I'm going to start with identifying our areas for improvement. So just to go over what we know is best practice during a code resuscitation. So it's a complex process that requires multiple coordination of team members and closed loop communication. I don't know about your hospital, but our hospital can be a little chaotic when we call codes here. We have multiple different services, and it's kind of a lot of people that show up. So they can be chaotic and challenging at the same time, because once the primary team of the patient shows up, they kind of have to take control of the code, and everybody else has to kind of go by the wayside. That doesn't usually happen a lot. You're always usually like, hey, come on, if you're not part of the code, please remove yourself. Clear leadership in a resuscitative event can prevent problems associated with in-hospital cardiac arrest, yet we don't really know what the experience level of the provider will be, and we don't really know what the experience level of the nurse can be. So when they don't have clear expectations and roles, they're confused, and it really can be a little confusing during a code resuscitation. And the code team functions best when team leaders and team members know their roles and they communicate effectively with each other. So knowing who each person in the room is, knowing what their role is, and kind of working together as a team for these patient outcomes. And what happened with us is we had a new medical director come on board. Her name is Karen Chase, and there was a lot of frustration from the bedside nurse and our APPs, our mid-level group. And what they were being frustrated with was, how are we going to be running our codes? Because we're a cardiac surgery service, so there are multiple different ways to code patients. What are we going to go with? What's our protocols? Are we delaying CPR? Are we not delaying CPR? Are we shocking or are we not shocking? Why are we having so many people in the room, these large crowds, when everybody doesn't have a role and they're kind of in the way when we have to do things to the patient? You know, what do our response team looks like? How do we get the team there? What about the equipment we're using? Does everybody know how to use the equipment? Is the equipment working well? Is it broken? Is it not broken? So these were all kind of things that came to light. And what happened, and the medical director approached me and I said, why don't we make a code team? We have a resuscitation committee for the hospital, but we didn't have a code team specifically for our unit. So bringing all these people together, a multidisciplinary team, we invited pharmacy, we invited APPs, we invited bedside nurses, we invited our equipment specialist, the guy that kind of deals with our equipment and orders stuff for us. And we kind of had to decide, you know, how are we going to run these codes? And we decided that debriefing on a regular basis was really going to help us with our process improvement. And we needed to come up with a debrief sheet. So as a code committee, we came up with this debrief sheet and we started utilizing it. And it really brought to light all of the things that were confusing and chaotic for our team. And I just kind of want to go over a little bit of why there is some communication, some confusion. So for cardiac surgery, there is something called CALS. It's Cardiac Unit Surgery Advanced Life Support. So this came from Europe. It was adopted in 2015 and really adopted by the Society of Thoracic Surgeons in 2017 as a way to resuscitate cardiac surgery patients. So they're a special select population where they have just had their chest opened and cut into, and they have these new sutures and new valves that kind of makes them special in resuscitation efforts. And what's the best practice with that? So best practice with CALS was, you know, the biggest differences between ACLS and CALS, because I can do a whole talk on this, just I'm going to get down to the nitty gritty, is for ACLS, you do one shock. For CALS, you're going to do 3 stack shocks. The 3 stack shocks allow us to bring 78% of the patients back with the first shock, 35 to 45% with the second shock, and 14% with the third shock. So our patients really need electricity first. And then what happens is if there is a surgeon on board that can open the chest immediately after those shocks, that's the preferred way to do it. But if nobody is here to do that, they go ahead and start CPR within 1 minute of the defibrillation. Another difference between CALS and ACLS is the dose of epinephrine that you're going to give. So for ACLS, you give a full milligram. For CALS, we're only giving 100 mics to 300 mics. And the reason being is we don't need blood pressures in the 300s on patients that just had cardiac surgery. So those sutures are very kind of fresh and new, and our valves are fresh and new. We don't want all that pressure to, you know, maybe blow a graft or something. So we like our pressures a little bit lower. And those are the major differences between those two types of resuscitation efforts. So we put it all together and we made a modified ACLS protocol for our patients where now, again, Lisa was talking about ECMO. ECMO was not prevalent back in 2017. ECMO is now prevalent in 2022. So instead of going right to opening chest, we can put on ECMO if it's an arrhythmia or it's an ischemia issue. If it's a bleeding issue, yes, we're going to go and take the patient back down to the OR and we're going to open the chest and we're going to do that. But we have kind of modified it where in about the 10-minute mark, we're deciding, is this patient going on ECMO or are we going to open their chest? And I'm going to hand it over to Lisa, and she's going to kind of explain how did we engage those key stakeholders to get on board with us.
So now came the fun part for us and the most challenging part. So our code committee got it together. We came up with a vision. Tammy and I working together came up with some protocols and the way that we wanted to run this resuscitation process. But now we had to bring it to our key stakeholders to get their approval and buy-in. And with key stakeholders, I'm talking about directors, administrators, so our chief of cardiac surgery, our director of the cardiovascular center, our nursing director of the cardiovascular center, our medical director of the ICU. So getting them involved early, it helps reduce and uncover risks and increases their buy-in. It also brings to light what barriers there are. And I remember the first time I talked about this protocol and wanting to use this mechanical CPR device, with our director of the cardiovascular center, the response I got was, those things are dangerous. Don't they hurt people? Don't they like crush ribs and break sternums? So that's what we had to overcome. And the truth to that is, if the device is placed properly, it should not be causing any harm to the patient. So once we got the buy-in to proceed with these protocols, then it was time to establish a multidisciplinary work group and get the whole team involved that were going to be part of that resuscitation design for the CV center. As Tammy talked about, that included our advanced provider group, our physicians, our bedside nurses, our shock team. And what we did with that group was we discussed the initiatives. We showed them what the current evidence was, why we knew that we could make this new protocol work with using this mechanical device, and we got everybody on board. And then what we did as that group was we identified what our top priorities were and what we needed to do to be able to create a code response team. So those designated roles, that extensive training, and a communication process. So in creating a code response team, so what our work group agreed upon was that all team members must be proficient in performing the skills authorized by their scope of practice. So for example, an APP, if they are going to be the team lead, they have to be trained, they have to be proficient, and they have to be confident to be able to step in that role and perform appropriately. High performance teams, in order for them to be successful, they must have the following things. So they must be clear about their role assignments. So Tammy's going to go into detail about roles again, but they have to know what their responsibility is. If you're the APP and you're coming to the code, you know that you are going to either be stepping up as the team lead or you are going to be the one assisting the team lead and reaching out to our attending physicians to give an update. Bedside nurses, you know that when you find that patient in cardiac arrest, you need to check for a pulse. You need to initiate the code response system to get people there. You need to be able to do those stack shocks and initiate CPR until the rest of the team's there. So being well practiced in resuscitation skills. So we knew that we had to have continuous simulation, mock codes, to be able to train this team so when they responded, everybody knew exactly how to step right into their role. They had to be knowledgeable about the algorithm, so ACLS, modified Cals. Everyone had to know exactly what they were supposed to do when they stepped into that room during resuscitation. And lastly, the most important piece of this, they had to be committed to the success of our program. So we had this little saying, teamwork makes the dream work. And, you know, we kept repeating that over and over again. And when we did these simulations, we wore these bright gold shirts that had our roles on there. So it was like thing 1 and thing 2, but it was RN1, RN2, APP1. We made it fun and we got everybody on board and we made it happen.
Yeah, Lisa, I just remember it really brought to light what everybody's role was, because not really does the attending always know what the bedside nurse's role was, or, you know, who did what and what was the expectation. So it was a really eye-opening experience for even like our residents, our fellows, our respiratory therapists. So it was a great time and helped us get it all together. So I'm going to just kind of review the roles that we came up with for our code response team. This is without eCPR. First of all, there's RN number 1, and that would be your bedside nurse. So the person that identifies the patient is in, you know, a code resuscitation event. They're going to go ahead and initiate the code response team, and they're also going to be responsible for those 3 stack shocks that we talked about. So their first priority is to get initiation of the team and then go ahead and grab the defibrillator, slap those pads on, and do those 3 stack shocks. By the time the 3 stack shocks are over, a second nurse should be coming in and our team leader. So they will go ahead and transition to being the med nurse because they know where all the access is. So they do defibs and meds at the same time. Secondly is the person that's going to provide the CPR. So make sure the device is placed properly, make sure the device is there, make sure that it's continuous and staying in the same place at all times. Anytime the device is not placed correctly, we immediately stop CPR and we get it placed correctly the way it's supposed to be, because we do not want to cause any harm to the patients. Third person is the team leader. So the attendings and everyone decided that the team leader should always be APP number 1. They wanted to be able to do these codes in the middle of the night on the weekends when attendings aren't here. So the attending became a mentor. And I know this is going to be kind of, taboo for everybody, but we only allow one attending in the room during our resuscitations, and they all came into agreement for that. So we were all grateful for that. If a second attending shows up, they just kind of hang outside of the room for suggestions or anything like that. But it's APP number 1 is going to run the code. They're also going to announce themselves when they come in the room so that everybody knows they're a team leader. And we also decided that when the APP number 1 asks, who's my recorder, that we should be saying our names, not saying I or he or she. We should say Tammy's recording. And it makes it very clear on who the roles are. So again, number 3 RN, we needed a recorder. So the recorder needs to be very strategically placed next to the APP so that they can give, timings of the defibrillation, timings of meds, the whole chronological timeline of the code event going on. Then we needed somebody to run the code cart in our medications. We want pharmacy up there. They are the experts in the meds, so we have them come to all of our codes. Secondly, another one that we have experts for is the airway. We usually have respiratory therapists assigned to our unit, two every day or every shift, and anesthesia. So if either one, whoever the first one is that shows up, they'll handle the airway, whether that's bag valve masking or intubation. We also needed a runner to get any equipment that wasn't there at the code. And that person kind of hangs outside of the room. They don't need to be in the room, but they go ahead and get all of the things that we need. And the last position I kind of want to say is the acute shock resource nurse. And Lisa's really going to go into what the acute shock resource nurse's responsibilities are.
And Tammy, one thing I was just thinking about before I get into the details of the shock role, one thing that is very important when you are creating a program is you have to make sure that this program is going to work when you have the least amount of staff. So when we were designing this, we were thinking about who was going to be here and available on nights and weekends. We couldn't make this program work if it was based on people that were just going to be here Monday through Friday. So just something to consider. Our shock nurses are here 24/7. Our APP group, which consists of nurse practitioners and providers, are also here 24/7. And that's why they were a big piece of this initial code response. So now onto the role of the shock nurse. And it is the joke here at our facility. Anytime we have something new that needs to be done, we just pile it on the shock nurse because we got them doing everything at this point. So whenever there is a code, whether it be coming from our ICU or coming from one of the CV center floors, the shock nurse will grab the ECMO bag, we call it, and it is a bag that has cannulas, access, everything you could possibly need to put someone on ECMO. We have since converted that to an eCPR cart now, and on top of that cart sits our mechanical CPR device. So when they have a code, they roll in with those 2 pieces of equipment with the 2 APPs. First thing they do is identify themselves. And if it is determined by our APPs that this is one of our cardiac surgery patients and CPR is in progress, they will immediately put the mechanical device on the patient without waiting for that 2-minute pause. And in our next couple of slides, I'm going to talk about this 2-step process we developed, so there's minimal interruption in CPR when that device is being placed. If it's identified that there is not enough access, all our shock nurses are trained to put in humeral head intraosseous catheter access, so we can make sure that we can get those ACLS drugs into the patient, right into their heart with less than 3 seconds. They also help confirm what the roles are in the room, making sure that all the roles are covered. We have them in charge of crowd control. And our way to manage crowd control is to very nicely ask, if you're not a part of our cardiac surgery team, could you please step out of the room? And if you don't, we give you a little tap out process, time to go. When we were first looking into designing the eCPR program, we did have the shock nurses get a pH through an iStat analyzer, but since we've done this, we kind of got out of the way of that. Now, within the first 5 to 10 minutes of code, it is imperative to make the decision how you're going to proceed. Continue with the code, go on ECPR, or open the chest. So if the decision was made to go on ECMO by the attending physician, it was the responsibility of that shock nurse to put out the ECPR response page from their shock phone. Every member that was on call and that needed to be there for this process was on that page, and they all had the shock nurse's phone number, so they knew where that page was coming from. If the decision ended up being to open a chest, say for tamponade, the shock nurse was responsible for contacting the OR to get that case booked and get the team in to proceed in the OR. So next we're going to show you this little two-step process that we have and how this came to be. Tammy, if you want to hold on just a second. I had a friend in EMS that sent me a video of the Alaska Fire Department and this process that they developed with placing the mechanical CPR device. In the way that they did it, they quickly lifted these patients, got the backboard underneath them, continued CPR, and then hooked up the device. So when we looked into doing this here, we came up with two barriers immediately. The first one, number one, is we did not have big, strong fire personnel at the bedside to help lift these patients. So we knew we couldn't do that. The second barrier that we had was we have a no lifting policy in this hospital. So Tammy and I played around with the mechanical device, and we came up with this way to log roll the patient, slip the device under, continue CPR, click it in place. And Tammy, if you want to click the video now, I'll go ahead and narrate through it. So here we have the bedside nurse performing CPR.
Hold on, Lisa. It's giving me a little problem. Can you go ahead and play the video?
So the bedside nurse is doing CPR. The acute shock resource nurse comes, gets the device out. They get the backboard in place, and they're going to slide it underneath there where they get it positioned perfectly. We did a lot of training to do that. So backboard's under, CPR continues. Now the device is turned on. It gets clicked in place on one side while CPR continues. Device is ready to go. There's a short countdown, 3, 2, 1. Maybe 5, 4, 3, 2, 1. The other side of the device is clicked on, plunger is pulled down, it's turned on, and we now have mechanical CPR running. So this took a lot of training with everyone, and we have now perfected this process about 5 seconds to get it on. So we're really proud of that.
Yeah, so the next phase we're going to talk about is executing. Creating this education and simulation plan. So we talked about identifying system issues. We evaluated our communication process. We assessed and evaluated team roles. We even decided what quality measures we wanted to kind of follow. So, we wanted 5 to 10 minutes to decide if we're going on ECMO, if we're going to open the chest, and we wanted 30 minutes to be on and running an ECMO. We also, did we decrease our times of interrupted CPR, and our time to defibrillation. So, and then we clearly delineated these roles and, our expectations of these, of the bedside nurse, of everybody that was in the resuscitation effort. And how did we do that? So we have a web-based training program in our hospital. Everybody probably does. Ours is called MyPath. So we came up with, an education program through MyPath where it kind of clearly identified what everybody needed to do. We put a policy and policy stat called modified ACLS and how, we were going to be running these codes, and we had everybody do them. But what really works is not them sitting at a computer kind of viewing these things online. It's the simulation. So we do weekly simulations, and we involve everybody. So that's what kind of make it works. So our attendings show up, so whoever's available. We know they're surgeons, so it's one of them shows up, that's great. We also have CCU docs that kind of come in and do this for us. You're gonna see a video in a second. This was actually recorded by our medical director for cardiology. And then with the simulation, we just kind of drive home everybody's kind of role. We do it, and we do it in a very learning kind of environment and approachable. We're not very like, oh, you shouldn't have did that, you do it this. We just kind of talk about it when we're doing it. And if the nurse is kind of weary, we slow it down. We say, okay, what is, your actual job here? What are we doing? And we'll go through each step with them. We have little paper that gives them like clearly what their role is and what they're supposed to be doing, just in case they, you know, forget or are a little bit too nervous during this. And Lisa and I kind of drive this process. We drive it every week. We're the ones that schedule it. We're the ones that kind of go ahead and get everybody on board. We also are a teaching hospital, so we have residents and we have fellows, and our cardiac surgery program is actually a resident program. So we have every one of our fellows show up because they can also cannulate to go on ECMO, and they need to understand what the acute shock resource nurse's role is, and they need to understand what the bedside nurse's role is. So they come up and they do these simulations with us. So it truly is multidisciplinary. Oh, and I don't want to forget perfusion. Perfusion comes up every time too. And then I'm just going to play this little video so it gives you a little snapshot of what our simulation kind of looks like. As you can see, the mechanical CPR device is going. Our bedside nurse is standing next to that, also giving meds. Our APP number 1 is up at the head of the bed next to the respiratory therapist who's bag valve masking the patient. We have our 2 cardiac fellows up front here. They're kind of cannulating to go on ECMO. And then our acute shock resource nurse is right behind them with a cart. It's a sterile cart, allowing them to get all of their stuff and assisting them. So, you know, the last step of our process is review. And, you know, how do we do this? This is a, you know, continual process. You know, I kind of want to pat Lisa and I's back a little bit. I don't really like boasting of myself, but the clinical nurse specialist role is an important one. And if you have one in your hospital, they can be your champion. You know, we spearhead all of this. We started it, we found the deficiencies, we got into the planning process, we pushed everyone, we kind of didn't let it go. And we did this on a daily and a weekly basis. You know, we didn't allow it to go away. So we got these processes in place. We evaluated at the 3-month mark, we evaluated at 6 months and 9 months, but truly we were up and running with this program in less than 3 months and functional with the program. And that was, for, you know, I guess, you know, attributed to how, you know, persistent we were in trying to get this together. And I do want to say this happened during our acute shock launch and the COVID pandemic 2020. So and it was a lot of work.
The new balloon pump as well.
Yes, and a new balloon pump. And we kind of, what we're getting reports of and what we're auditing, you know, the staff is reporting an increased knowledge with our code algorithms and a new confidence when they're running codes. Debriefing has really become a staple where it was a taboo before. We really utilize it often, and it helps us with our process improvement. Our interruption in CPR is down to less than 5 seconds. And the monthly simulations allow us for our continuous feedback and process improvement, because evidence-based practice changes on a monthly, on a yearly basis. So we kind of work that in with our simulations, and I hope to continue it. Lisa's kind of going to run through what it might look like for a code response in action.
Yeah, just real quick, because time's winding down here, right? So I love this picture in here, right? It's about how teamwork makes success. So just a quick synopsis of what happens in a code response. So the bedside nurse identifies the patient's in cardiac arrest. No pulse, hits the call button, yells for help, gets the defibrillator out, gets those pads on, bam, 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 3 stack shocks, doesn't work, starts doing manual compression, or 2 APPs, and the acute shock resource nurse arrive, identify it's a cardiac surgery patient. They get that Lucas right on the patient, mechanical CPR is going, roles are identified, our APP is leading the code, we're giving meds, 5 to 10 minutes go by, and a phone call from the second APP is made to the attending surgeon. This is what's going on. What do you want to do? Decision is to go on ECMO. Shock nurse puts the response out. The whole rest of the team arrives. Meanwhile, the shock nurse has got that tray set up with everything ready for access and cannulation. The physicians arrive. Access goes in. All the while, we're still coding. We still have mechanical CPR running. Once that access is in, we take a pause. We look at the rhythm. We pause the mechanical CPR. Are we still going on ECMO? Yes, we are. We give heparin. Cannulation happens. The circuit's there, and we've got a patient on ECMO. And with the development of this program for 2021, we decreased our time in 2020 from 47 minutes down to 26 minutes in 2021. And we increased our survival rate from 10% in 2020 to 50% in 2021 for survival in eCPR. So very proud of that.
Yeah, we're kind of running out of time, but we just wanted to highlight how this mechanical CPR is in the ED with our acute shock resource nurse. So we'll just say we get alerted when a STEMI comes in via a page. Anybody less than 60 years old, the acute shock resource nurse is grabbing the ECMO bag anyways and the mechanical CPR device, and they're going down to the ED with the intensivist. Once they get there, if eCPR is decided, they're going to put out the eCPR page. And the eCPR team comes in, and we've done one in 15 minutes, and the patient actually survived. So that's just a real quick synopsis of that. And this kind of concludes our talk for today. We really appreciate you guys, and we're going to hang it over to Angela for our questions.
Wow, thank you so much, Lisa and Tammy. That was a great presentation. I know I have some questions personally, but I want to get right to everybody else's. So my question is, because we do have one of these devices in our institution, do you use it for every single code, or just ones that are going to be more prolonged, or one where you have an increased isolation? What are your thoughts about that?
It's an immediate response. We utilize it in every code that we go to because we want to do the same thing every time. So we don't wait. As soon as it's at the code, we place it right on the patient immediately. Since there's hardly any interruption in CPR with it, we go ahead and just use it.
That's wonderful.
And now we actually have other services asking for our shock nurse to bring that mechanical device with them.
Yes, and I think another question I have, just trying to determine if, regarding this device, do you have any way of determining your data? Like, for instance, we have different pads that we've purchased so that we can monitor our time off chest, so we can get some very good data about our resuscitation. And what we found is with this device, we're not able to get that information from our pads. Do you find that to be problematic, or do you have certain data that you can get from this company that tells you specifically what's going on?
So fortunately, they do have a program that is web-based that you can definitely do that. That's our next step with that, because we just recently purchased the defibrillators from the same company, and they connect, and then we'll be able to get that raw data, like real-time data, and that's kind of the next piece that we're working on.
Yes, that's wonderful. I did have a question from Samantha regarding the prone position. That's going to be a challenge to utilize this if the patient is in prone position, correct?
Yes.
And I would figure that if somebody's coding, we are going to turn them back into supine position, but she just wanted some clarification on that.
Yeah, that is the protocol here. So if someone does cardiac arrest, there are proning and turn teams that are immediately in that room, kind of doing that quick burrito and getting that patient flipped back over and getting that device on.
Absolutely. All right, well, Catherine also asked, do you incorporate this MCPR training during ACLS or BLS courses or research classes, and do you use RRT as experts in this care?
So we utilize RQI at our hospital. So we research quarterly. We don't teach the rest of the hospital the modified ACLS protocol because we only have cardiac surgery patients in the cardiovascular center. So we don't want, unless they decide, them using 3-stack shocks and any other service. So we just teach the CV center, and we do updates on that twice a year, just separate from what the hospital mandates them to do.
Okay, and then with your normal research and CPR and BLS, do you incorporate this training, or is that something you're thinking of doing? Yes.
We don't. It's two different kind of entities. So
Okay.
Nursing practice is the one that does the BLS and ACLS tracking and research to make that. But like I said, RQI has taken that all away. It's really easy to track and all of that stuff. So.
Awesome. A question from Ryan. Are there any studies that show use of the MCPR in a pre-hospital care setting without the use of supraglottic airways?
It's Lisa.
So I can speak to the use of the mechanical CPR in EMS. And all of the EMS providers in our region do use the devices, the mechanical devices. You know, as part of our pre-shock program for acute shock, we have been doing training and education with our EMS providers. We are now getting notified when they have these STEMI patients that are potential ECMO candidates, that we get this call and we now have a team waiting in the ED for them to arrive. So again, Tammy talked about that patient that we had flowing on ECMO within 15 minutes. This was one of those cases where EMS called it in.
That's great. That's great. I love getting EMS involved. I think it can make a big difference in our outcomes in a lot of different, with a lot of different scenarios. Somebody wondered about the cost. I don't know if you feel comfortable speaking to that. They said this would have been amazing to have had at their COVID facility during the COVID time, but any thoughts on cost of the device?
Yeah, I do have one thought on that. How do you put the price of saving a life?
Yeah.
So no matter how much this device costs, we look at the outcomes that we have had and how many lives that we have saved because of it, and it was worth every single penny spent. There's evidence out there very strongly supporting this now. So if you're interested in the facility, get that evidence out, get it to your administration, and get this organizational change going, because it's worth it.
Absolutely.
Yeah, like again, putting a plug in for CNSs.
Yes.
CNS, that's what we do. We save the hospital money. So, you know, you have to prove it. You have to prove the need for the product and that it's going to improve patient outcomes.
Absolutely. Speaking my language, girls. RT, one of the questions from Tina was, so RT was removed completely from ECMO? And I think when they say RT, do they, I'm not sure, do they mean respiratory therapy?
So respiratory therapy. So there are times when we will go on 10 ECMOs at a time, and it just straps us for resources.
Sure.
So the initial group of ECMO specialists that we had, that at one point was 66 staff members. That, with the transition to this program, has dwindled down to 10 of them. So the respiratory therapists and nurses from other units, we do keep a second layer out there. So when, again, we have that large number of ECMOs on, we will use those respiratory therapists to sit ECMO and help the shock nurse as well. We do quarterly training for everyone that's on our team, quarterly sign-offs in order for them to be able to maintain competency. And for those remaining ECMO specialists, we do have them sit the circuits once a quarter, again, to maintain competency. So they're still around. We love them.
Yeah, respiratory is the experts in oxygenation, so we need them on our ECMO team.
Yeah, and if you're like us, we just need more of them. It's like they're, you know, they're struggling too with how many we can get in our institution. So another question came from Justin. Are you able to share the education and policies or order sets? Is there anything like this that you would mind sharing with us?
Right now, or we could give our email out and we can share things with people. We'd be happy to.
Awesome, thank you. I do believe we'll put their email address out there. Tracy, you can address that. And I think I can answer this question for Stephen, but the question was, do you follow the CSU-ALS guidelines? And I heard you speak to that, Tammy, so I don't think we need to really address that. You definitely use those guidelines. And then Steve asked, is it possible to share your debrief sheet? I know at our institution, we're also really big on debriefing after every single code. So do you have a special form that seems to be working for you guys?
We do.
Yeah, I kind of did the research on that. I researched the AHA debrief sheets that they have on their website. I also did a lit search for it, but I also utilized the units here in the hospital and found that really nobody was doing it. We have a pediatric hospital attached to us, and they seem to always be one step ahead of us.
But they have lots of CNSs over there.
They do. They had debrief sheets, so I kind of copulated a whole bunch of different ones and made one that was best for our unit. So I can definitely share it. It would work in any cardiac surgery unit.
Awesome. Awesome. One of the questions that came from Catherine, did you leave the cardiac board under the patient or remove it before placing the Lucas device?
So when you place the Lucas device, nothing can be under the patient. That is the backboard. So that's one thing when you'll learn if you start using mechanical device, You cannot have any like hover mats, any sheets, anything under the patient when you place this board. It's got to go right to the patient's back.
Yes.
And again, with the extensive training that we have done, if it's in our ICU, we have the emergency button on the back wall that nurse knows to hit immediately, and that Lucas device is mechanical CPR device is immediately on the way. The same thing for the cardiovascular center. Our floors are directly across the hall from us. When that code bell goes out, our shock nurses are immediately grabbing that eCPR cart and that mechanical device, and as soon as they enter that room, no break in compressions, it is get that process and get that device on. So we don't even worry about getting that backboard underneath the patient. We respond so quickly.
That's great. That's right. Then it helps with that timing as well. How about the Cath Lab? You had mentioned those patients coming in with the STEMI. Are you able just to go ahead and keep that continuing through cardiac Cath Lab?
Absolutely.
That's awesome.
So I will say they were the first to bring the Lucas into the hospital. I'm sorry, the mechanical CPR device.
Oh, it's okay. It's okay. Hard not to say those words.
We work very closely with the Cath Lab too. So these patients, oftentimes we'll get them on ECMO and get them rushed right over to the Cath Lab.
Awesome. Well, you guys, it looks like our time has come to an end. My goodness, there were still some more questions, but what a great presentation. I just want to remind everyone that continuing education for nurses and respiratory therapists, this activity has been approved for 1.0 contact hour. You can go to www.sacstesting.com/SL, and you will need to register at the test site. Complete that evaluation form, and upon successful submission, you will be able to print your certificate of completion. And support for this educational activity has been provided by Stryker. There is an archive/on-demand version that will be available on www.savinglivesnow.org, and the on-demand version will be accredited for nurses and respiratory therapists. And I'm going to turn this over to Tracy.
Thank you, Angela, and thanks to both of our speakers today for such a great presentation. We'd like to remind everyone immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback, as well as their CE certificate of completion. In 1 hour following the conclusion of this webinar, you'll receive an email with instructions and this link to obtain your CE credits. That is www.sacstesting.com/SL. We'd like to thank everyone for attending our webinar today, and we hope you have a great rest of your day.
Thank you, everyone.
Thanks.